I wanted to just start with reminding us all how complicated the upfront adjuvant therapy is for ER-positive breast cancer. In postmenopausal women, there are a variety of options, including 5 years of tamoxifen. We now have 10 years of tamoxifen, possibly from the ATLAS and the ATOM trial. We have MA17 with 5 years of AI after 5 years of tamoxifen in sequence. And we have the Big 98 and the IES models, which is the so-called early switching. All of this is familiar to people in the audience and results in complex treatment decisions that, depending on circumstances and availability of the different drugs. To make matters more complicated, we have 3 types of aromatase inhibitors. So this is a complicated landscape, and I just want to give some insights. The Oxford overview that was published by Mitch Dowsett and colleagues a few years ago looked at a meta-analysis of all the upfront adjuvant trials. This was prior to, this did not look at ATLAS and ATOM, obviously, because the results of that are more recent, and it did not include MA17, but it did look at the upfront 5-year treatment, one against the other. And consistently over the meta-analysis, there was a highly statistical significant benefit at 5 and 8 years of follow-up at that time for the meta-analysis, 9.6 versus 12, 15.3. So the AI was superior to 5 straight years of tamoxifen, and the conclusion was that AI significantly low recurrence rates versus tamoxifen in both the straight upfront cohort and the switching cohorts. That there was no reduction in mortality in the first meta-analysis, although subsequently the Big 198 has had a mortality advantage demonstrated for that switching trial. A switch to AI associated with significant reduction in breast cancer mortality, which was 0.7% at 3 years and 1.6 at 6 years, and no increase in non-breast cancer deaths, which is important when considering possible toxicities. Big 98 with this design has a 12-year follow-up update, and the monotherapies were compared to each other. And what this analysis showed was that for low and intermediate, and you need to read the paper to see what they define as low and intermediate, but for the lower and intermediate patients, there was really no difference between the different treatments, including tamoxifen was satisfactory. And all arms in the intermediate risk also looked similar with the letrozole, but tamoxifen was inferior. Tamoxifen is tracking at the bottom. So you can see the code down here. There were four types of therapies looked at in the composite risk. 4 types of strategies. There's the upfront pure letrozole, there's a switch TAM to letrozole, and then the back to front letrozole to TAM and tamoxifen. But in the high risk, letrozole 5 years appeared better than either of the sequences. So 5 years of letrozole upfront, 5 years of the AI seemed to be superior to switching, or to whichever way you did the switch from TAM to letrozole or letrozole to TAM. So it seemed that upfront AI, at least for the higher risk ER-positive patient, is a better strategy, but for the lower risk, it might be that tamoxifen alone or any combination of tamoxifen and letrozole. And the advantage of the combination is obviously both toxicity and cost. It's still, although they come off patent, the aromatase inhibitors, it is still cheaper to use tamoxifen than aromatase inhibitors. So, and then the combination of exposure of the different toxicities of the 2 drugs limits the toxicity exposure by doing a switch. So tamoxifen for a few years followed by letrozole for 3, or the other way around, is probably adequate for a large number of these patients. One of the interesting new findings that has been presented at the meetings, there was one at ASCO and there was one also at San Antonio, is that it would appear that in invasive lobular breast cancer, that the aromatase inhibitors are superior to tamoxifen. So this looks like a subset of ER-positive disease that possibly one should select. I think these data still need confirmation because they're still quite small, but this was the second paper that has shown that, the second presentation, and we are currently looking at this in the MA27 study, which is a very large study, to confirm this finding. The other interesting new finding, which was not shown for letrozole versus TAM in Big 98, but was shown in the ATAC trial, is that the differential benefit of aromatase inhibitors over tamoxifen seemed to be abrogated by body mass index. So once you got above a body mass index of 25 to 28, in this category here, where you still see the forest plot is in favor of the aromatase inhibitor over tamoxifen, you lose that benefit of AI relative to tamoxifen as body mass index increases. And this is a complicated discussion, but it may reflect the fact that body fat obviously is one of the primary sources of peripheral aromatase and estrogen production in postmenopausal women. Although when one measures plasma estrogen levels in women treated with therapeutic doses of the AIs, you see suppression below the detection limit even in patients with high body mass index. So this may also be something to do with peritumoral aromatase production, either in the primary or not in the primary in this case, but in the metastases or micrometastases. So the explanation for this is not clear, but it's a very important finding. It was not replicated, as I said, in Big 198, but was shown in the ATAC trial. You know, we presented and published recently the results of the MA27 study, finally, this very large study that originally had a 2-by-2 randomization with celecoxib, which was a much more interesting design, but ended up just being Coca-Cola versus Pepsi-Cola. And exemestane is a steroid with possibly and probably a better effect on bone metabolism because of its anabolic steroidal function than anastrozole, which is an imidazole and a pure bone mineral density, a stronger bone mineral density effect. And we have data to show that actually in a very large bone sub-study that's in submission for publication right now, showing that exemestane probably causes less bone reduction than anastrozole as an upfront 5-year therapy. The efficacy was absolutely identical. I draw your attention to how well these patients did after a median follow-up of 4.1 years. 93% of the patients remained disease-free in both arms of the study, with about 95% in node positive and about 87 or 88% in node, the other way around, in node negative and node positive, respectively. The side effect profile from MA27 did show a difference. These were carefully collected symptoms of menopause, the two drugs versus each other. And if you look, there are in this category here, you see the statistically different, very mild differences of liver function abnormality reflected by the steroid, and really nothing to say about the other hypercholesterolemia or myocardial infarction or other things. So although there were small differences between the drugs, they did in the end look pretty similar. There were fewer cases, which was statistically significant, of osteoporosis developing on study on the anabolic steroidal aromatase inhibitor than on anastrozole. So you can see here, this was statistic. But clinically, it was only 31 versus 35% of patients reporting new onset of osteoporosis. There was no clinical fracture difference between the two arms. I wanted to just show that I'll show some of the data from our own trials because we've been involved in I showed yesterday the prevention, which was a placebo-controlled trial of exemestane in prevention, and the MA27 data, which I've just shown. And I want to talk a little bit about some of the new data that we have on extended adjuvant therapy with MA17 and the design of MA17, and compare that and contrast it with some of the recently presented findings of Atlas and Atom. So just to remind you, of course you know it, here in this little corner I've put the design of MA17. After 5 years of tamoxifen, patients were randomized to placebo or letrozole. I'm going through this again, it's old data, but I want to show it in light of the fact that Atlas and Atom have just recently been presented. This trial was powered for an overall disease-free survival advantage at 4 years of 2.4%. This was chosen for MA17 because that is what the Swedish had used as an advantage of 5 years of tamoxifen versus 2 years. That trial that showed a 2.4% advantage of one therapy against another at 4 years in disease-free survival led to a worldwide change in practice from 2 years of adjuvant tamoxifen to 5 years. Many people may be too young in the audience to remember when that was done, but that's what made us go from 2 years of adjuvant tamoxifen to 5 years. So using that as a disease-free advantage, MA17 overall almost doubled the benefit that we were hoping for by showing 4.6% absolute difference in disease-free survival between the two arms, letrozole, placebo. And importantly, and I was asked to show this particularly yesterday by one of the organizers, the important thing to show is that even in the node-negative patients, the benefit exceeded the target goal for the overall population of the trial. So it's powered for 2.4 and shows 2.7 in node-negative. And in the node-positive, it vastly exceeded that by 7.5% absolute advantage. And both of these were highly statistically significant. And this is why the trial stopped early at an interim analysis. And you can see, I beg your pardon, you can see on this slide, here's disease-free, distant disease-free, overall survival, and contralateral breast cancer, even after tamoxifen, even after the prolonged effect on contralateral breast cancer reduction, you can see a very strong reduction in contralateral by extending therapy. And this was not shown in detail in the Atlas or ATOM trial, the breakdown of the sites of disease, but you can see every single site of recurrence was decreased. Now, although overall survival in the intent to treat population initially was not shown to be significant, it was shown, and I thought this was interesting to show you this morning. I just pulled out this slide. We did look at just the double receptor positive patients, the kind of luminal A with patients, although in this time we don't have HER2 status, but we assume quite low. But here we've got 73% of all the patients, 3,809, had double receptors. And in those patients, there was a statistical survival advantage for both node-positive and node-negative patients. So those are the patients that most benefited from extending endocrine therapy, those with double receptor positive. So that's another clue as to who might be the best candidate for this kind of extended therapy. We subsequently have published a paper with the IPCW. It's an analysis that accounts for patients crossing over, because we had like 75% of patients crossing over. And when we did an adjustment for crossover analysis, the trial was positive for overall survival advantage in all subtypes. So this was the same analysis that was done for Big 198, showing a survival advantage for the patients if you account for crossover. So MA17, the extended therapy, actually caused a survival advantage in all patients for intent to treat, as well as for the ER/PR positive patients, and also particularly for the node-positive patients. Now, contrasting this with the Atlas data that has been published in the Lancet, the important thing to point out about this study is, although it is presented as a study for all patients receiving adjuvant tamoxifen, it's really important to notice from the data that only 9% of the patients in this trial were premenopausal at diagnosis. So this is predominantly a result of postmenopausal patient. And the thing I'm going to show you in a little bit of detail on the next slide is that in contrast to MA17, when the postmenopausal patient was switched to AI, and you had this dramatic reduction in all sites of disease and a survival advantage within the next 5 years, there was no advantage at all, in any way at all, in the patients in Atlas or ATOM between 5 and 10 years. So when the patient gets to 5 years of tamoxifen and then you extend it, there's no difference from taking a placebo for the next 7 years, actually, up until year 12. And then finally you see a change in disease-free and overall survival very late. So it's very difficult to imagine advising a patient to take such a strategy when during this time there's no advantage to the therapy. And I will show you that here. If you look here, years 0 to 4, you see that here there's a statistical significant advantage to extending. There is no advantage to extending the treatment between years 5 and 9, but in years 10 you see the first advantage emerging here. So nothing between the first 4 years, nothing between the next, and only after 10 years of randomization do you see this advantage. And that was shown also in here. You can see here that there's no advantage in the years 5 to 10 after treatment with extended tamoxifen. Contrast this with MA17. When you begin the aromatase inhibitor, this is the hazard ratio of the patients as they go through time. And you start off in the first year with a 0.52 hazard ratio, which is a 48% reduction. By the time you get to 48 months, you've got a reduction of almost 80%. So there's a very strong ongoing benefit of taking aromatase inhibitor after tamoxifen in this analysis. And here's the Atlas study for premenopausal women. Again, only 630 out of 6,200, which is less than 10% of the patient. And the advantages shown for extending tamoxifen were not significant for the premenopausal patients that are shown here. this crosses the confidence boundary, and there was no significance in that. And it was only in the large postmenopausal subset that the significance was shown. In fairness to the data, however, the trend is in the same direction as the overall effect, and it's probably real, but you would have needed a lot more premenopausal women to demonstrate a significant advantage in this analysis. So the important thing to remind everybody treating patients is that in MA17, there were patients who began their tamoxifen when they were premenopausal and became postmenopausal by 5 years and then were switched. So we did an analysis of 800 women who were initially premenopausal and then became postmenopausal. And in those women, there was a highly statistical significant advantage of switching in both node-negative and node-positive patients. In fact, there were no recurrences in the control arm in the node-negative patient whatsoever versus an 11.5% in the control patient. So there was a very, very significant advantage to switching on MA17 if a patient had started premenopausal and ended up postmenopausal. And that is the majority of breast cancer patients who are young when they get breast cancer. They either become menopausal through chemotherapy or just by virtue of age and time as they pass through the initial 5 years of tamoxifen. Now, we have looked recently, and I'll just go through this a little bit quickly. We've looked at how to reduce the numbers needed to treat in the extended adjuvant setting. And I will just present to you some of the data we've compared Oncotype, Mammoprint, and IHC4 and BCI. These are the signatures that are creeping into practice for use of treatment decision in the subset of patients. In the upfront data from ATAC, if one looks upfront, you can see that if you compare breast cancer index is a signature that was developed by my colleague Dennis Segroy at Mass General Hospital, and it's really a 2-gene signature plus a molecular grade signature combined. It's a 7-gene signature. And it and IHC4 and recurrence score were able to predict early recurrence in ER-positive breast cancer. All of them were significant for their prognostic performance. However, when we looked, they were all significant, you can see. When we looked at late recurrence, IHC4 and recurrence score fell away. I think Chuck Peru showed some data for PAM50 also predicts the way breast cancer recurs. So you can see here that breast cancer index on the primary tumor is highly significantly predictive of recurrence, late recurrence in patients treated with ER-positive breast cancer. And here you see a highly statistically significant advantage for breast cancer index predicting a recurrence in the extended setting. And this was not true for IHC4 or the recurrence score. And so this led us to be able to divide the patients. 60% of the patients that we looked at, we did a primary tumor case control 1-to-2 analysis of patients with recurrence and not. When we looked at that, we were able to divide patients into this breast cancer index low score and the higher score, intermediate and high, tracked together. So you had about 13.5% of patients at risk for recurrence, and 13.5% risk of recurrence in about 40% of the patients, and a very low recurrence in the other 60. So 60% of the patients had a very low recurrence. And you can see this here. And we also found that the index predicted for response to letrozole. So I'll show that to you now in an ATAC. So in MA17, there was a highly statistically significant benefit in patients who had high H/I, but not in the patients with lower, enabling, and this paper just came out, I think it's coming out on Monday in the Journal of the National Cancer Institute, actually. And we looked in ATAC as well, and here again we saw that the patients with high HI did worse, but on letrozole, the patients with high H/I did as well as those with low H/I. So a very strong treatment effect predicted by the signature for patients taking the aromatase inhibitor, but not for patients taking tamoxifen. So this is a really excellent way. This data needs corroborating by other data sets, but I think this is an excellent way of dividing the patients into those at risk and those who will benefit from taking an AI particularly, which combined will really reduce the number needed to treat and expose fewer patients to treatment. So in summary, there's a substantial risk of recurrence. Endocrine therapy for 5 years does not eliminate that risk, and that's important to recognize in all patients. We will see some data about what the residual recurrence risk is after taking AI. We have the MA17R trial, which will report in about 18 months, and we have NSABP B42, which is looking at extending an AI beyond 5 years when the patients have already taken it up front. The options beyond 5 years, in women postmenopausal, at the completion of 5 years of tamoxifen, letrozole, switching to letrozole is probably, based on the data, a very much superior option than extending tamoxifen for a further 5 years. In women that are still premenopausal, at the end of 5 years of tamoxifen, choosing an extension of tamoxifen may be an option for the patients, particularly those at higher risk. I just want to quickly end by showing some comorbidity data, which is really important. You can see here that level of comorbidity. This is something that's been published increasingly in the literature. And you can see that breast cancer death, if you have no level of comorbidity of 4.1, goes down and down and down. In other words, this is a competing cause of death. And we've published this data in MA17 and MA27. If a patient is getting over 70 years of age and with comorbid risk factors, there's an increasing competing cause of death of non-breast cancer death versus breast cancer. And this obviously has to be taken into consideration when considering extended therapy. I think that in the interest of time, I just wanted to show actually one thing that I really want to say about aromatase inhibitors. First of all the data of quality of life and all the end organ toxicity has normally been shown in trials comparing against tamoxifen. And tamoxifen has beneficial effects on many end organs, including bone density particularly, and bone fracture risk. In the placebo-controlled trials that we conducted with aromatase inhibitors, we did not see, as I showed yesterday, any increased risk of fractures with the aromatase inhibitor against a placebo, and we didn't show that in MAP3, and we didn't show it in MA17. And the quality of life was extremely well maintained in patients receiving aromatase inhibitors when compared to placebo. You can see here from MA17 there is a difference, a statistical difference, but clinically it's extremely small, and the quality of life data reported was almost indistinguishable between the two drugs, drug or placebo. So patients really tolerate it, and particularly patients who've reached 5 years of endocrine therapy, they have already adjusted to taking endocrine therapy. Those who had severe side effects have usually dropped out, and those candidates for extended therapy probably tolerate treatment much better. This is the last slide I just want to show about the side effect risk. When you compare anastrozole to tamoxifen and the clinical risk of clinical fractures in all the trials, and you see this big difference, Rob Coleman looked at the hormone replacement versus placebo data in the Women's Health Initiative, and he adjusted for the same age patient. And you can see that tamoxifen mimics the known protective effect of hormone replacement therapy on fractures. And the AI fracture rate is very similar to placebo, maybe a tiny bit bigger, but really almost identical. So I think the myth that aromatase inhibitors cause fracture risk is really built out of the data that came out of all these comparative trials comparing it to tamoxifen. So my summary is there are tumors that are so low risk they will not alter patients' remaining life expectancy. There are gene signatures with prognostic power that can identify low-risk patients, and chemotherapy may be avoided, maybe even endocrine therapy can be avoided in some patients. Early and extended adjuvant editing may be guided by new predictive signatures like H/I or PAM50, and quality of life must be taken into account, but doesn't differ that significantly from placebo. Thank you very much indeed.